Good afternoon, all of you. So today I'm going to discuss about primary immune thrombocytopenia or primary ITP, and I hope you all familiar with the topic. So it's a 30 minutes presentation with 15 slides. So let's start with some common clinical presentations of ITP. 32-year-old previously healthy female presented with petechiae and ecchymosis for 3 days duration. So it's acute onset. Systemic review and physical examination were unremarkable. So her platelet count 10,000 on admission. So the other one, 3-year-old child developed spontaneous onset skin bruises and epistaxis. He is otherwise healthy and no lymphadenopathy or organomegaly. Again, a full blood count showed marked thrombocytopenia is isolated, platelet count 8 for 8,000. A term baby born to a mother with ITP found to have low platelet count of 100,000 at birth with no bleeding manifestations. So as you know, there are several differential diagnoses for thrombocytopenias in different age groups. But in these type of clinical scenarios, ITP on higher in the list. So what is ITP? It's an acquired autoimmune disorder characterized by peripheral blood thrombocytopenia. It's isolated thrombocytopenia. If other cytopenias present, it could be dual pathologies or other cause for cytopenias. Could be immune, but we called ITP if it is isolated thrombocytopenia. So there are two types, primary ITP versus secondary ITP. So I'm mainly discuss about primary ITP today. So primary ITP, there is no underlying etiology in primary. Secondary ITP has there are several underlying pathologies like connective tissue disorders, SLE, rheumatoid arthritis, autoimmune thyroiditis, could be infection associated, commonly viral infections, HIV, hepatitis C, hepatitis B, and H. pylori also will recognize the infection for secondary ITP. Some lymphomas, lymphoproliferative disorders also can cause secondary ITP. Antiphospholipid syndrome, inherited immunodeficiency syndromes, especially in children and young adults, and drug induced. So the main difference between primary ITP and secondary ITP in terms of management. So in secondary ITP, the underlying cause also should treat. Pathophysiology of ITP is multifactorial and complex. So autoantibody mediated, it's antiplatelets autoantibodies sensitize platelets and destruction through the reticular endothelial system. And cytotoxic T cell mediated, again type of immune destruction. Molecular mimicry and immune complex formation normally seen in viral infection and H. pylori infection. Antibodies produced against the pathogen cross-react and destroy platelets. Relative thrombopoietin deficiency. So what is thrombopoietin? It's a growth factor for the platelet production. So megakaryocytes are the precursor cells in the bone marrow to produce platelets. So in ITP, because of peripheral destruction, bone marrow megakaryocyte mass increase and the turnover of platelet production is also increased. So because of that, the growth factor thrombopoietin get some relative deficiency. So ultimate result is immune mediated destruction of platelets or suppression of platelet production by bone marrow megakaryocytes. So natural history, the platelets mainly involved for the primary hemostasis or bleeding pattern mucocutaneous. Serious bleedings are uncommon when platelet count more than 20 to 30,000 because the platelets are very immature and very active in ITP. So Serious bleedings, if happen with platelet count more than 30,000, there should be some kind of platelet dysfunction. It's again can explain because antibodies can cause platelet dysfunction as well, but uncommon. So diagnosis of primary ITP, there is no gold standard test to confirm the diagnosis, so diagnosis is by exclusion. So what we should exclude then, the other causes of thrombocytopenias. So when you see thrombocytopenia on full blood count, it could be pseudothrombocytopenia or it could be true thrombocytopenia. So why pseudothrombocytopenias? Could be EDTA-induced platelet aggregation, so clots in the sample. So you should repeat the full blood count with or without blood picture and confirm first. So other causes are viral infections commonly seen, for example dengue infection, drugs, alcohol, excess alcohol intake, liver disease, splenomegaly, yes, and bone marrow infiltrations from hematological or non-hematological malignancies. Other pathologies like myelodysplastic syndromes, microangiopathic hemolytic anemias like DTP, HUS, DIC, and there are several other inherited thrombocytopenias, especially seen in children. Some vaccinations, following vaccinations, for example, MMR vaccines, we can see, we have seen some transient thrombocytopenias, sometimes chronic. So, before diagnosis ITP, we should look at all these thrombocytopenic causes and exclude, as well as if you suspect primary ITP, exclude the secondary causes as well, as I mentioned before. So detailed clinical history and physical examination is must. Again, then follow the investigations, full blood count, blood picture. In ITP, you can see in the blood picture, normally we see large platelets, but it's not pathognomic. We can see large platelets in some other thrombocytopenic conditions as well. Direct Coombs test, clotting profile, retin count, again according to the differential diagnosis, liver functions, viral studies. We routinely do HIV, hepatitis B and C for all suspected ITP patients, and other viral studies like EPV, CMV, it's optional. So I put stars for the optional investigations. It all depends on the clinical condition of the patient. H. pylori infection, again optional investigation. If it is geographically prevalent or if you clinically suspect H. pylori, you can ask for relevant investigations like urea breath test or stool antigen tests. We normally do ANAs as a routine investigation, and other immune markers again depends on the clinical findings. Radiological assessment, if you suspect lymphomas or malignancies, you can ask for a CT. Otherwise, routinely ultrasound scan abdomen to see any organomegaly, lymphadenopathies or any liver pathologies. Bone marrow examination is again not for all suspected ITP patients. There are indications. If patient is more than 60 years of age or presence of atypical clinical or laboratory features. So what are the atypical clinical features then? If patient is having B symptoms or patient complains bone pains, back pains, any presence of organomegaly, lymphadenopathy, yes. Abnormal laboratory features, if abnormal blood picture findings like dysplastic neutrophils, cells, blasts, or any other cytopenias. So then bone marrow examination indicated. So what are the other ones? So failure to respond or relapse following first line treatment of ITP. and prior to splenectomy. So terminology wise, ITP can be divided newly diagnosed if diagnosed within 3 months, persistent 3 to 12 months, chronic if more than 1 year. So this picture you can see increased megakaryocytes in the bone marrow biopsy or refined biopsy. These large cells are megakaryocytes. So other than increased megakaryocyte or normal megakaryocyte mass, the other findings of the bone marrow is normal in ITP. So how would you manage primary ITP? It's actually a big decision. There are several factors contributing to the management, and it's actually an individual judgment. So if patient is having significant bleeding, yes, we should treat. Otherwise, if platelet count less than 20 to 30,000, we start treatment. And for other patients, if any risk of bleeding such as prior to surgery or procedures, for anticoagulation, antiplatelet treatment, we should achieve the target platelet count for these procedures and treatments. In advanced age and high-risk comorbidities for bleeding, yes, we have to consider, and high-risk activities, lifestyles causing prone to trauma, we have to treat. And we should consider tolerance of the side effects, availability of treatment. In Sri Lanka, we don't have all kind of treatment, so we should practice according to the availability. And patient expectations and financial resources. So the main thing is major goal for treatment of ITP is to provide a safe platelet count with minimum treatment toxicities and optimum health-related quality of life. We normally aim a normal platelet count. We aim a safe platelet count for all patients. So treatment-wise, we can divide treatment into first line, second line, and emergency treatments. So emergency treatment indicated if we need urgent increment of platelet count, such as prior to urgent surgeries or patient present with active bleeding, for example ICH. So in this situation we consider combination of treatment, mainly IVIG with steroids, most probably methylprednisolone. Most patients need high-dose platelet transfusion in this situation, but otherwise platelet transfusion is not indicated. That is because the underlying pathology is immune. So we should look at the other general measures such as to stop drugs that reduce platelet functions. Consider antifibrinolytics like tranexamic acid, and if all fails, we go for other medications such as IV anti-D, vinca alkaloids like vincristine, vinblastines, thrombopoietin receptor agonist, I will discuss later, and emergency splenectomy might be an option rarely. So first line treatment of ITP mainly corticosteroids. We normally practice prednisolone, oral prednisolone, IV methylprednisolone for emergency situations, and dexamethasone again a pulse treatment. So corticosteroids, when we prescribe, we should consider side effects profile as well. So gastric protection, so osteoporosis depending on the age groups, can precipitate psychosis, impaired blood sugar, hypertension, all sort of side effects should address. IV immunoglobulins, normally in emergency situations when we need rapid increment of platelet count. IV anti-D, it's uncommonly used in Sri Lanka, and I haven't seen in UK even. So mainly practiced in licensed countries, and I think that is because serious side effects because of IVITD can cause severe intravascular hemolysis with DIC and multi-organ failure. So IVITD, if you prescribe, patients should be RHD positive and not splenectomized. So these are the first line treatments. Second line treatments, there are lots of medical treatments and surgical treatments, splenectomy. So medical treatment wise, we have several new medications, uh, promising ones. Thrombopoietin receptor agonist. L-Thrombopag is an oral medication, response around 70%. Romiplastim subcutaneous weekly, again good response. L-Thrombopag is a new one, recently approved FDA. So considering those medications, we only have L-Thrombopag in Sri Lanka currently. We don't have Romiplastim or L-Thrombopag. Side effects wise, it can cause thrombosis and bone marrow fibrosis, liver impairment, which is black box warning sign for L-Thrombopag. Other one is rituximab. I hope you all familiar with rituximab, not only used in ITPs. It's anti-CD20 monoclonal antibody. It's weekly 4 doses. So, side effects wise, we should screen for hepatitis B prior to the medication because it can cause hepatitis B reactivation. Otherwise, lots of infusion related reactions, so needs pre-medications prior to the treatment. And rituximab can cause transient neutropenias, definitely immunosuppression, and very rarely progressive multifocal leukoencephalopathy. So what is progressive multifocal leukoencephalopathy? So it's a rare fatal kind of demyelinating CNS uh, condition because of JC viral reactivation because of the immunosuppression. Spleen tyrosine kinase inhibitor, fostamatinib, is again a new drug recently approved by FDA, and we don't have it. And azathioprine, cyclosporine, cyclophosphamide, we commonly use medications, Danazol, Depsol, MMF, and vincalcaloids very infrequently. Surgical treatment is splenectomy. So normally considered for patients with chronic ITP, diagnosis more than 1 year from the diagnosis, and so we should address for splenectomy sepsis and vaccination prior to splenectomy, as well as So patient education is again important, and antibiotic prophylaxis following splenectomy. Yes. So other treatment options for adult patients if failing first and second line treatments. So it's again difficult to manage and clinical dilemma. So around 20% of patients do not responding any kind of treatments, and 20 to 30% of splenectomized patients eventually relapse. So in this situation, we should exclude accessory splenic tissues as well. So for patients who failing these medications, we have very limited options. most of the patients living with very low platelet count, around 10, with fairly good quality of life, because the available options have very toxic or side effects. So what are the options? We can switch one TPO receptor agonist to the other and try sometimes effective. Combination chemotherapies, again toxic because of immunosuppressive effect. Alemtuzumab is again potent immunosuppressive drug used in T-cell lymphomas and lymphodepleting agent in conditioning treatment prior to bone marrow transplant. Hematopoietic stem cell transplants as last option, and clinical trials. We don't have clinical trials here. In other countries, if available, patient can enroll. So few things on ITP in pregnancy. So diagnosis is similar to non-pregnant state, but there are various pregnancy-specific thrombocytopenic conditions such as hypertensive conditions, HELLP syndrome, PET, liver pathologies, acute fatty liver in pregnancy, microangiopathic hemolytic anemias, and physiological wise gestational thrombocytopenia. But all of these, ITP is the commonest cause for thrombocytopenia in early pregnancy, because other causes can worsen thrombocytopenia state with the progression of gestation. So treatment wise, first line treatment we can try, but second line treatments we consider teratogenicity and the side effects. So we should manage both mother and the neonates during and following delivery. So antibodies can cross the placenta and can cause neonatal thrombocytopenia. So we should avoid traumatic deliveries such as forceps delivery and scalp blood sampling, and should check cord blood for full blood count. If depending on the platelet count, the monitoring treatment will be decided. Normally, if platelet count less than 30,000 for a neonate, or if having bleeding, we will try with IVIG. ITP in children, again, there are lots of differential diagnoses, including inherited thrombocytopenias and immune deficiency syndromes. So prior to diagnosis, we should look at all these differential diagnoses. Because the toxicity of the treatment, we normally try to watch and wait for in children after educating the parents and the patient. Otherwise, short courses of corticosteroids, IVIG, IVIG as first line, and selected second line treatments if indicated. Thank you. So, general measures for all patients with thrombocytopenias. So, you should remember to avoid advice on to avoid contact sports, IM injections, avoid drugs can cause platelet dysfunctions such as NSAIDs, antiplatelets, good dental care, patient and family counseling, and carrying a diagnosis card. So these are my references. Thank you so much, and wish you for a happy and virus-free 2021 in advance.
Yeah, we will have 5 minutes to ask questions before the lecture is started. Because thank you very much for finishing a lot of time. Sandaru. So if you got any questions, so you have 4-5 minutes regarding thrombocytopenia. diagnostic test? I don't know whether it is still being done or.
No, the specificity sensitivity wise it's not indicated actually.
So that
Not available in Sri Lanka anyway. So there are no confirmatory diagnostic investigations. Okay, thank you.
So then have you seen people have been dying of this, like, because I can remember, like, when just I came here, there was this young girl who came with a very short history of like severe thrombocytopenia. I mean, she was very, very good at, admission, but then gradually her platelet count started dropping, and then despite of whatever the treatment, then we ultimately ended up with plasmapheresis as well. So, but she never responded to that, and then she ultimately developed ICH and she passed away. So, what do you suggest, like in such patients, who just progress this thrombocytopenia very rapidly within a short period of time?
First of all, we should exclude other diagnoses, definitely.
Bone marrows and all, like we couldn't find any other cause for that as well.
Yeah, as I told you, it's around 20% patients. It's actually refractory for any line of treatment. So, very limited treatment options available. And we don't have all the treatments in Sri Lanka compared to the other countries. So we can actually TPO receptor agonist are promising agents, very good response. We have now Eltrombopag and we're trying and patients showing good response. In acute situations, those are the first line treatments. Plasma exchange not recommended according to the very recent guidelines 2019. Combination of treatments.
But still there are patients who
Yeah.
do not respond. So absence of